So one of the questions that we look at is most of these studies were done in patients who were very high risk or had documented atherosclerotic cardiovascular disease. Suppose the person hasn't had a heart attack, doesn't have carotid disease, doesn't have peripheral arterial disease, but just is a high risk patient. Now this is maybe outside of the true label, because the label is for persons who have atherosclerotic cardiovascular disease to show these benefits. Do you think the other patients would benefit? Melissa, what do you think?
I do, just because of some of the other effects that we've talked to. The main reason these drugs were developed were for the change in glucose levels, but we do see weight loss with most of these medications, especially with the GLP-1 receptor agonists. And we all know that that belly fat and that insulin resistance and adiposity is a huge risk factor in and of itself. So I think not only getting the glucose down, but the weight down as well. And those two classes, SGLT2 inhibitors and GLP-1s, as you know, are very low risk for hypoglycemia, which is something we do worry about in our cardiac patients. So
that's a good point on the hypoglycemia, and I'm gonna come right back at you on that, but let me revisit what I asked. So the person hasn't had a heart attack, no stent, no peripheral arterial disease, no stroke, you still consider these medications?
I would still consider it. I know it's not in the label specifically for that, but both of these medications are in the ADA and ACE algorithms for the treatment of type 2 diabetes, and we know that our patients are at risk, and we know that these are effective classes of medications that will do what we want them to do as far as maintaining glycemic control and a little bit of weight loss and even a little bit of blood pressure. So I don't see a reason for not using them.
Now, I'll go back. You said there was no risk of hypo, HYPO, low glucose?
Exactly. Unless it's in combination with a secretagogue or insulin, both GLP-1 receptor agonists and SGLT2 inhibitors don't inherently drop the glucose on their own to a hypoglycemic level. Certainly if you're adding it to addition with a sulfonylurea on board or someone with basal insulin on board, you need to cut that back. But I know that you can prescribe a GLP-1 to a patient and have a fairly low risk of hypoglycemia as long as there's no secretagogue on board.
All drugs have side effects, so SGLT2s, and we're going to go into the GLP-1s next, but let's stick with the SGLT2. What kind of side effects you tell your patients about?
So we talk about really watching for orthostatic blood pressure changes, really making sure patients know the symptomatology of that if you stand up too quickly, are you getting dizzy, are you getting weak or fatigued, to make sure they report that, to avoid dehydration. And then of course there's the genital mycotic affections, and we talk about making sure that you special attention to hygiene, especially if you're a female patient that is prone to UTIs or yeast infections or uncircumcised males as well. So we do have to touch on that just to make sure the patients are aware of those things.
So Peter, you would think we probably, despite its benefit for heart failure, benefit for protection against progression of CKD, need to be careful with over-diuresis. So if the person's on high-dose loop diuretics, and you add the SGLT2, you may get some of the complications that Melissa just mentioned.
You know, that's been my experience, is I'm almost to the point of just automatically cutting the existing diuretic regimen down when I start one of these drugs, because there's such a predictable diuresis. And I do agree that there's kind of an initial adjustment phase that patients go through on these drugs. And it's about 3 months where this isn't the type of drug one can prescribe and say, oh, see me in 6 months. I really think patients need to be followed up, and invariably one will see some volume contraction and a slight increase in BUN and creatinine. One can see a slight increase in hematocrit with this. And we have to make some adjustments to baseline diuretics. There's some patients that actually come off their thiazide diuretic when they go on this class of drugs.
So we have empagliflozin, canagliflozin, dapagliflozin. The dapagliflozin was a mixed bag. I don't think it had the same great outcomes that we saw with the first two. Now, I'm not saying that the medication was inherently different, but the study that DECLARE did not really show the same level of outcomes. Why would that be, Chris?
Well, they did move in a big way to include many patients without prior atherosclerotic cardiovascular disease. So they did have a sizable, roughly 7,000 with disease, but 10,000 without. And the MACE effect was, there was no reduction in cardiovascular death and minor stroke in those without prior disease, so the primary prevention group. And that probably led to some of the lack of big benefit, but all the trends were the same. So in those with known disease, it wasn't statistically significant, but the same idea in the meta-analysis of reduction, about 15% or so. And there's another ertugliflozin is the fourth agent, and that trial is still ongoing, should finish up at the end of the year. So we'll get even more data coming to understand this class, and then a series of trials in these other areas. So in kidney disease, Credence will be out later, in a month or so. But then other agents have kidney-dedicated diseases, and then a series of trials in patients with heart failure. So the benefits that we're seeing now are being formally studied in nice trials, so that we'll get much more understanding of how to use these properly and safely.
I wanted to point out, though, in the Timmy DeClare's trial with dapagliflozin, that the event rates in the placebo group compared to the placebo group in the empagliflozin or canagliflozin trials, the events were about half. And I think a big factor that played into this was renal function at baseline. With dapagliflozin, they were following the current prescribing information at the time, where patients with estimated GFR below 60 weren't entered into the DAPA trial, where some patients lower than that did get into the EMPA. And as things have changed now, we're realizing that the renal risk is a risk not only just for progression of kidney disease, but it's a cardiovascular risk. So at lower levels of renal function, then these cardiovascular risks amplify and the effects of the drugs can be seen.
Chris, I'm going to ask you now to go over the GLP-1 agonist outcomes, but before I do that, I'm going to give Seth, Melissa, SGLT2s, you want to give us 2 take-home points on how you feel these drugs will be used going forward?
Well, I think the drugs should be used very, very frequently. I agree with Melissa that there's no reason to have to restrict oneself to the PI for established cardiovascular disease because they're already approved diabetic medications. So I think we need to embrace them. I was concerned about Fournier's gangrene, just in terms of frightening people. It's so incredibly rare, yet I thought people would be so frightened that they would stay away from the SGLT2 inhibitors. And I wanted to ask you, in your practice, actually, if you don't mind, have you seen that? Is that a...
We really haven't, and I think we've also seen fewer UTIs and yeast infections because I think we were aware from the onset to start educating patients and not wait for that patient to come back to us and say, hey, I've got a really bad UTI. I also think we're a little bit choosy. If I have a female patient whose blood sugars are 300 or 400 and I know they're really going to be having a lot of glucose in their urine, I might pull their blood sugar down before adding an SGLT2 inhibitor to it. So I think just really having that forethought of where to start the drug and when can mitigate some of the side effects. But like you said, I think a really good class of medication where you get kind of a double bang for your buck is how I see it. You get really good glycemic response, weight loss, and then that cardioprotective effect.